RA. You'll see a comparison here between rheumatoid arthritis and osteoarthritis in the same chapter. just very short paragraph maybe. So what is RA? Chapter 34. RA is an autoimmune disorder. So we had an autoimmune disorder earlier, ITP. What was the treatment in ITP? Correct. So what was the mainstay? Immunosuppressants, right? So this is another autoimmune disorder. So what's the treatment here? Same exact thing. There will be different drugs, of course, because there are certain parts of the immune system that cause the signs and symptoms of rheumatoid arthritis. Since this is affecting those, then it will be drugs targeting those types of immune system cells. Okay. So autoimmune, so with any other autoimmune disorder, we have no idea what's causing it. We just suddenly develop it. It can affect all ages. So it's between the 3rd and 6th decade of life. So between 30 and 60 years, and then the incidence goes up after the 6th decade. So we don't know exactly because, again, it's an autoimmune disorder. All we know is the patient develops antibodies against what? The joints. So this results in joint inflammation and pain. So the condition is progressive. It does get worse over time, especially if the patient refuses to get treatment. Now, what do you associate rheumatoid arthritis with? Just honestly, right now, if you hear rheumatoid arthritis, pain, but what age group do you usually associate it? Older. Okay. So therefore, when it says here that the 3rd decade patients are also affected, what will these are people in their 30s. What will they say if they're told that, oh, you have rheumatoid arthritis, this is the treatment? What will they say? Right. So they'll be in denial, right? That's an old person's disease. I'm not gonna get treatment. Plus, it's my joint factor. Yeah, they're in pain, they're painful, but it's not that bad. So what will they tend to say when the doctor offers treatment? Not right now. That is a bad idea because what will happen to the joints meanwhile in their 30s up until their 60s? It get worse because is there anything that will stop the antibodies from destroying them? No. So that's what I mean by it's a bad idea to forego treatment. Of course, you can't force anybody to get treatment, but this is the consequence if you forego treatment. If you refuse, let's say you're in complete denial, no, I'm not ready for that. I'm too young. Exactly why we treat you while you're younger so that the joint damage doesn't get worse. So this is not testable, but let me just describe how it destroys it. So it occurs inside novel tissue. So the inflammation occurs there, and then the antibodies slowly destroy the synovium, which is the cartilage of your joint. So it breaks down collagen, edema, and then that's what causes the inflammation and pain. So no more cartilage. There's now breakdown. So now there is bone to bone plus the swelling, and this affects unlike osteoarthritis, which is the wear and tear. Osteoarthritis affects everybody who have whose job has a physical toll on the body. Let's say construction workers, people, utility workers, or even nurses, because are we on our feet most of the day? Yes, 12 to 14 hours a day, we're on our feet. So that does a lot of wear and tear. So that's what we get with osteoarthritis. Osteoarthritis is a degenerative joint disorder, which affects wear and tear, usually elderly. However, the RA is not degenerative. This is inflammatory in nature, autoimmune inflammatory joint disorder. So this can affect younger people. And unlike osteoarthritis, which affects the big weight-bearing joints, such as your hips, your knees, this one affects the fine motor joints, the fingers. Okay, the fingers, the wrist, the shoulders. So the fine motor joints are affected here. So how can you do ADLs if you can't? Let me show you the deformities. Imagine your fingers now look like this.
Can't see it.
Oh. How can you do the paperwork now after you do number 1 in the toilet? Can you do the paperwork? Can you close your button shirts?
No.
Can you zip or unzip your zippers?
No.
So it's hard, right? Can you drive?
No.
So is it debilitating? Yes, the patients with RA, depending on the severity, can go into disability. Okay, that's how serious the deformities can be. So we really encourage treatment so we don't get to that point. Manifestations, as I described to you. So this is inflammatory. So therefore, any inflammatory disorder will increase ESR and CRP. Okay, so your blood test will show that. What do you want? And the pain is the most concerning to the patient because they can't get moving, especially early in the morning. So here are this of course of the disorder. So early morning, they'll have the joint stiffness. So it's very hard to get moving, to get started when they wake up. What will be better for this patient? A hot shower or a hot bath? A shower, because if they do a bath, can they get up from the bathtub? No, that's the problem now. So and the pattern is symmetrical. Unlike osteoarthritis, where it's usually one knee, it's either the left knee or the right knee, the left hip or the right hip. This one is always both wrists, both index fingers, both shoulders. Okay? It's always symmetrical. So there's symmetrical joint pain, swelling, warmth, erythema. Very hard to move. And then later they will form nodules on the joints, which are permanent. Not only the hands, wrists over time, as the disease progresses, then it'll affect the large weight-bearing joints now. Okay. So here's the ulnar deviation. So the wrists will look like this. Okay, they'll either go this way or this way. Okay, plus the swan neck deformities of the fingers. So these are the nodes that I mentioned earlier, but these nodes typically are not really painful, but they are palpable. Okay, so they are deformities of the joint. Again, not tender, however, they will limit mobility of the joint.
So can the pain last longer than the stiffness can last longer than an hour?
Yeah, it can last all day. So these patients we'll get to the intervention shortly. These patients may develop Raynaud's phenomenon. Have you discussed this in MedSurg 1? These are vascular disorders. Okay. Anyway, it's not discussed in this chapter. It's in arterial disease chapter. Raynaud's phenomenon is, as described here, cold and stress-induced vasospasm. So your hands literally turn blue during winter or when you're under a lot of stress. Okay, so it's an ischemic, it's a vasospastic disorder of the arteries. It's an arterial disorder. As I mentioned, so your lab results will have a ESR and CRP. Another is there will be a positive ANA antibody as well, which is also seen in lupus. And of course, the rheumatoid factor will be positive. Management. So there'll be a combination of physical therapy here as well as pharmacologic therapy. So the goal of treatment is to decrease joint pain swelling so that you go about your activities of daily living and then continue doing your job, and of course, minimize disability. So treatment, the most economical treatment is a DMARD. DMARD, number one example is methotrexate. DMARD stands for disease-modifying anti-rheumatic drugs. So the cheapest option is methotrexate. This comes in IV as well as PO. Most patients will start on PO methotrexate. And of course, there are side effects, which will be mentioned shortly in the same chapter. Others are the following. You've heard of hydroxychloroquine, right? I mean, this was made famous in 2020. No, the anti-malarial drug. Okay, this is also used in lupus. In the case of lupus, it's used because it decreases the ability of the skin to absorb ultraviolet rays. These are the more expensive options. There are TNF. TNF is tumor necrosis factor. These are tumor necrosis alpha inhibitors. So what are these? These are the cytokines involved in the inflammatory process, meaning the symptoms of rheumatoid arthritis causing the joint swelling, inflammation are these particular cytokines. So what are cytokines? These are pro-inflammatory proteins responsible for triggering lymphocytes, other cells in the immune system. So therefore, if you stop the pro-inflammatory cytokines or pro-inflammatory mediators, then you will not activate the lymphocytes. Make sense? Because what produces the antibodies really? It's the lymphocytes, right? So therefore, if you stop the lymphocyte activation by inhibiting these, because these are the ones that activate lymphocytes. So therefore, instead of targeting the lymphocytes, you will target the pro-inflammatory mediators. Meaning, if you stop these guys here, then you will stop the lymphocytes from being activated. Meaning, because do we need all lymphocytes to be inactivated? No, because we need them to fight cancer, we need them to fight viruses, etc. We just don't want the symptoms of rheumatoid arthritis, which is caused by these things, because these are the ones that will activate the lymphocytes. Therefore, don't touch the lymphocytes, touch the activators. Does that make sense? Okay, so now we will have drugs that will inhibit, drugs called TNF-A inhibitors. We have drugs that are interleukin-1, IL-1, IL-6 are interleukins. So because we have about 12 interleukins, we'll have the list shortly. It's in a table. Now, that's for the disease itself. Now, we have to treat the symptoms as well. What's the number one annoying symptom? Pain. Okay, so for pain, the only pain medication that really works for an inflammatory type of pain are NSAIDs. So we have different types of NSAIDs. Unfortunately, NSAIDs will have, because are these NSAIDs taken a few a day or like a lot of times every day? A lot, because they have severe pain and swelling in the joint. So therefore, patients will be taking the NSAIDs a lot. So the consequence here are heart disease, kidney failure, as well as peptic ulcer disease. So we have to protect the patient from these harmful side effects. So we'll talk about those drugs used to decrease the gastric irritation and ulceration in another chapter. That's in the peptic ulcer disease chapter. But you've heard of mifepristone, right? The abortion drug, mifepristone. Okay, so another drug in the same class called misoprostol, also used for abortion, is used to protect the GI tract of the patients taking NSAIDs. And of course, these are childbearing age patients, correct? So therefore, what should we make sure? Okay, either they're not pregnant when they take it, or prevent pregnancy while they're taking that drug. We'll discuss opioids next week. So opioids may be used, but really opioids are not the best choice here because, again, this is inflammatory in nature. So opioids here will really cause more problems than solutions. So other non-pharmacologic interventions are the following: relaxation techniques, yoga, heat and cold applications, and warm showers will be good. Now, if something is inflamed, what do you do with that body part that is inflamed? Do you keep exercising it?
No.
It's already inflamed. Do you want to keep exercising it? No. So therefore, what is the patient's advised to do? Rest. Okay. So they will be encouraged to take naps in the afternoon. Okay, rest your body. Okay, rest that body part. Take plenty of rest. That's your best intervention for inflammation. There are, of course, surgical interventions. We'll discuss them shortly, but they're expensive. Have you heard of diclofenac? This is like the brand name. Vytorin. You've seen it on TV. Okay, anyway, this is a topical NSAID. So it's still an NSAID, however, it's topical, not an ointment. So you can put it on the knee, on your hands. This will not help. So patients with obesity plus rheumatoid arthritis, that will put additional stress on the joints. Steroids are only used during an acute attack. If a patient has severe symptoms, then they'll be used in we will put the patient on steroids for a few weeks. Okay, but we really don't want to put the patient on steroids for a long time because it causes Cushing's syndrome. We'll discuss Cushing's syndrome next semester under adrenal disorders. And here are the foods that we encourage them to have. Okay, high protein, vitamins. Now imagine you're in your 30s and you have all the symptoms here. You have the fatigue, the joint swelling. You just don't feel good. How is your psychosocial status? Will you develop anxiety, depression? Okay, so that's on top of the disorder. It affects the patient's mood as well. Because you're supposed to be out and about, right? Not stuck in the house, in the couch all day because you're in pain. And here are the self-care. And these are your teachings. Now let's go to the drugs. Find the table. They may be found under the lupus because the treatment is really similar to lupus. Right here, table 35-2. Yeah, page 1072. So as I said, the treatment for patients with rheumatic disorders, which means these are autoimmune in nature, are similar. So rheumatoid arthritis treatment is treated with same or similar drugs used for lupus as well. So here are your NSAIDs for pain. Okay, so this is the topical we mentioned earlier. Then you have the pills, ibuprofen, because there are two sets, COX-1 or COX-2 inhibitors. So here are the drugs. So we mentioned already the hydroxychloroquine. And then we got the, what's the generic here? Okay, sulfasalazine. Now, sulfasalazine is typically used for Crohn's disease. Have you heard of Crohn's disease? Okay, so sulfasalazine is for that because Crohn's is also autoimmune. Then we've got, here's methotrexate, azathioprine, cyclophosphamide. These are all immunosuppressants. We have cyclosporin. Here are the TNF-A inhibitors. These are almost exclusively for rheumatoid arthritis. You've probably seen the commercials on TV. Adalimumab is Humira. Have you seen commercials for Humira? If you watch TV, you've seen Humira on TV. Etanercept is quite expensive as well. This is Celltype. Also on TV. Abatacept. Rituximab is a injection. This is a subcutaneous injection. As mentioned here, this is usually given with methotrexate for better effects. For patients who do not respond to the usual treatments we mentioned earlier, they will be placed on anakinra. Right here. So used in moderate to severe RA, meaning we've exhausted the other more common interventions and the patient doesn't respond to adalimumab, to methotrexate, then we will try anakinra. Okay, this is interleukin-1. And as mentioned, steroids will be used only during a flare-up, an acute attack, okay? Severe acute attacks. Then they'll be placed on steroids. Why steroids? As I mentioned earlier, this will cause broad inhibition, meaning it will inhibit the entire immune system. Whether or not that white blood cell participates in joint inflammation or swelling, they will all be inhibited. Therefore, what are the side effects? Also very systemic. Look at the side effects when you put on steroids. This is what we call Cushing syndrome. So there are more. These are just a summary of Cushing syndrome, but that's what you're going to have. In addition to this, patient will have developed obesity, particularly truncal and neck obesity. Okay, so that's Cushing syndrome. Right, so imagine you looking like that, Yannick. You'll have... No. You don't understand. These develop in a few months. Unlike obesity, do you get obese in a few months? No, it takes years, right? It takes a long time to become obese.
Shots in my back. Is that?
That's local though. This one is systemic because these steroids here are taken by mouth. These are oral steroids. Right? So the patient develops Cushing syndrome, which may not be life-threatening. However, is it nice to look at?
No.
Okay, let me just give you a picture. That's how you will look, Cushing syndrome. That's a drawing. Let's look at a real person. Here. That's Cushing syndrome.
Oh, wow.
That's Cushing syndrome before and after. Okay. Again, the development is in a few months, okay, not years. It develops pretty fast. And that's just the appearance. Plus, look at the other symptoms that accompany it. Sugar rises, blood pressure rises, you develop osteoporosis, which puts you at risk for fractures. Not mentioned here, this will become ulcers. The GI irritation will develop, make the patient develop peptic ulcers. You'll have hair in places where you don't want hair.
What? Oh.
Okay? And then there's mood changes leading to psychosis.
Your chin, yeah, mustache. If I see you.
Your legs, your chest, yeah, around your nipples.
Around your nipple,
So yeah, you look like a man. You'll have facial hair, mustache, beard, everything, the whole 9 yards.